Hi everybody, this is Dr. Peters, and I'm going to do a wrap-up video on hypertension and coronary artery disease. So first let's start with hypertension, and I'm just going to go over a few basics before we get into treatment and things like that. So how to measure a blood pressure. It's really important to know how to measure it so we make sure it's more accurate. Studies actually show that the manual blood pressure is not as efficacious or as valid as using a machine, but in my own opinion, I still like taking manual blood pressure. So these are the criteria regardless. You have to make sure that the patient's more relaxed, because if the patient's rushing somewhere, and I work in outpatient, so when a patient comes from the waiting room, gets weighed, they're nervous, and they get in there and they take the blood pressure, it's usually always higher, and then I make sure that I recheck it again, which is recommended. In the hospital inpatient setting, you have to make sure that they've been relaxed at least for 5 minutes. That's the guidelines or recommendations. You want to also make sure if they are sitting up, you want to make sure that they're sitting in a chair, their feet flat on the floor, not crossed over. We talked about the resting, making sure they're not talking through it, because again, anything can bring your blood pressure up, so we want to try to get the best baseline that we can. No caffeine, no alcohol, and make sure that you use the correct cuff size with the patient, because that really will make a difference and throw it off. Now, if you take a blood pressure in both arms, then you take the highest blood pressure, and that's what arm you use to check the blood pressure every time. Those are the best practice recommendations. The other thing that's really good to do is, which inpatient you are rechecking the blood pressures, but in an outpatient visit it is recommended to check it twice during an office visit. All right, so now that we talked about how to take a blood pressure, what is a high blood pressure? I know back in the beginning of your education, you learned what a high blood pressure is, what a normal parameter is. But there are guidelines that we have to use when we are prescribing medications. And I know you guys aren't doing the nurse practitioner role or advanced practice, but it is really good to know how the classifications are with blood pressure and why we treat people with certain medications and maybe multiple medications. So if we look at what's optimal, it's 120/80, less than 120/80. And there's categories called pre-hypertension, stage 1 and stage 2. This helps guide treatment. And this also helps guide risk factors. So if they are more at risk for a stroke. So if someone that is stage 2, equal or greater than 160 or equal or greater than 100, we know that they are at high risk for a stroke. It doesn't mean stage 1 is not, or pre-hypertension, but it's something that you have to monitor. It becomes more dangerous the higher it gets. So your pre-hypertension is 120 to 139 and 80 to 89. How do we treat that? It's usually with lifestyle change. And this is one thing that I do notice out in practice. I commonly see that if their blood pressures are in between these, it's often ignored and often said, okay, we'll just watch it. But it is really good at this time to have a red flag up to say, okay, we need to talk about some lifestyle changes, which we'll talk about in a minute. Stage 1 is higher, and then stage 2, it's even higher than that. These people in stage 1 or 2, they need medications usually and lifestyle change. So regardless, everybody needs a lifestyle change, but when do you add medications in? It's important to know, because we want to reduce the risk of having a stroke. We want to reduce the risk of cardiomyopathy and congestive heart failure. So how do we diagnose it? It's an average of 2 readings on 2 separate occasions. So they can bring in their readings from home, and then I can see a high blood pressure and diagnose them with hypertension. They can come in once, and I'll get a high reading, and if it's, say, in the pre-hypertension range, I'll recheck it. If it still is, I'll have them go home, and then when they follow up, we check it again. If it's higher, then they get treated. So you don't have to know this last sentence that I told you, but I really just want you to understand why we're doing what we're doing, why people are treated, and with 2 medications and 3 versus 1 medication or perhaps none. So now let's talk about modifiable versus non-modifiable factors. Regardless, if you have hypertension or coronary artery disease, or any other disease for that matter, you have things that you can change, that you have control of, and then there's things you don't have control of. For example, you do not have control over your genetics, your sex, or your age. So if you have hypertension, there could be a genetic component to that. Males have a higher likelihood. Also, African Americans have, or Black people have a higher incidence of having hypertension, and as well as your age as you become older. And then when we talk about modifiable, people that don't exercise, they don't eat a proper diet, and they have some elevated cholesterol. This is when we think these are lifestyles. So this is what we're doing for teaching. exercise, making sure they're eating a low-fat, low-cholesterol diet, and making sure they're watching their sodium intake. And so these are modifiable versus non-modifiable. And I tell patients that, okay, you might have some genetic component, but that means you have to work harder on these things because you have this, or because you have both of these. And there's some people, fortunately, that can go through life and not have any of these issues, but many people do. Another thing is obesity. All right. So now we're going to the types of hypertension. There's primary and then there's secondary. So most people have primary hypertension, which again, we can't find a cause for it. It could have some genetic reasons, aging, they're more sedentary. We can't really find out an identifiable cause. And secondary, the difference with that is that they do have another cause. And how do you treat that? You treat the underlying cause to correct the secondary hypertension. These people, there's certain criteria. They have very high blood pressure, usually comes on suddenly. We usually see it in younger people or all of a sudden older, but it usually is a sudden onset and very high. And they don't have a family history and they're not obese. And when I say very high, we're thinking greater than 180 over greater than 120. That would alarm me to wonder why these patients have elevated blood pressure. Another thing with secondary hypertension, they usually don't respond to medications very well. So these are all red flags to say, is there something else going on in the body that we possibly could fix? And one thing could be a renal stenosis. So the arteries in their kidneys can be stenosed. And so the blood flow is not getting through, and therefore it's constricted, and then the blood pressure goes up. Also, diabetic nephropathy, meaning kidneys, not neuropathy, nephropathy. So again, kidney damage. Something wrong in the tubules, the glomerular disease. The tubules become swollen, and therefore things can get backed up, and you can end up having hypertension. Polycystic kidneys. So there's a common theme here with kidneys. There's also other reasons that you can have secondary hypertension. Cushing's disease. There's something called pheocytochromatosis or chromatoma, and it's a tumor on the adrenal glands. And the adrenal glands, remember, help in that whole renin-angiotensin system and regulate blood pressure. And sleep apnea is another one, sometimes pregnancy. So these things are things that possibly can be fixed. If you have polycystic kidneys, that's difficult to fix. If you have renal artery stenosis, they can always go ahead and put a stent in, try to fix or optimize the kidney function as best as possible. And then these people are on medications, and these people are on medications. So how do we treat? Well, exercise is a given. It's really important for our cardiovascular health to make sure that we're working out the heart. So we don't want to work out the heart too much because then that is hypertension. So when you work out, your blood pressure naturally goes up, but it's a healthy elevation in blood pressure. Hypertension, high blood pressure, means your blood pressure is up most of the time. And I tell my patients that think of your heart as a muscle, and you don't want to overwork your muscle. So what happens? It hypertrophies, it becomes thickened, it enlarges that muscle. So over time, if you have years and years of constant stress on your heart muscle, it's going to become enlarged. And that is the name of cardiomyopathy or left ventricular hypertrophy, and these people end up with heart failure as they get older. So that's why treating this stuff early on is very important, which includes exercise intermittently to exercise the heart muscle, to keep it strong, to keep it pumping. Diet is another one, low fat, low cholesterol. Although there's controversy now with what kind of diet is healthy, but I'm still teaching right now the standard of low fat, low cholesterol, and medications and overall lifestyle, smoking, drinking excessive alcohol, and what is safe alcohol amount. What's been established is that men can have 2 drinks, let's say 2 beers, and women can have 1 beer a day. That is the recommended. And one hard liquor drink, 2 for men, 1 for women. All right, let's talk about medications now. I've just put down a few. There are lots of different classes of blood pressure medication. I often have patients say, why do I need to take 3 blood pressure medications? And I have to say, well, your blood pressure is regulated in different parts of your body, so we need to target those different parts of your body to get that blood pressure down. And there's a method to the madness on who gets what medication and the dose, etc. So when we look at this, the diuretics, thiazide diuretics, it is one of the first line or first recommended medications for patients with high blood pressure. It works really well. It works in the distal tubule of the kidney. It can think about potassium. Potassium can be depleted, so you can end up with a lower potassium because remember where it's happening in the tubule in your kidney. So there is that potential for potassium lowering, not as much though as getting a loop diuretic. It goes much lower and that has to be monitored. For blood pressure, unless they're inpatient and they have heart failure, that's a reason why they would get a loop diuretic, which is Lasix. But in the outpatient setting, they could be on Lasix for maintenance for congestive heart failure, but for hypertension, usually we don't see them on Lasix, like I said, unless they have heart failure. But we'll see patients on a thiazide diuretic. Hydrochlorothiazide is very common. These people need to be monitored and watch their kidney function, and we need to watch their potassium so they don't become hypokalemic. Let's switch over here to ACE inhibitors. That's another medication. Now with this potassium, the ACE inhibitor can retain potassium. So many times patients will go on a thiazide and an ACE inhibitor. ACE inhibitors, your ILs like lisinopril, quinapril, and it's a fine balance. So the potassium that's retained versus the potassium that's lost, it ends up balancing out, so it works pretty well. So ACE inhibitors, think angiotensin converting enzyme. Remember, it blocks formation of that angiotensin converting enzyme. So it's an inhibitor, ACE inhibitor. And that's, if you need to go back and review that, the renin, aldosterone, angiotensin system, I would recommend doing that. ARBs work very similarly. With this, it blocks those angiotensin receptor blockers, so it blocks the action of the angiotensin. ACE and ARBs are, I call brothers, cousins, whatever you want to call them. They're very closely related. They're working in that same pathway. ARBs tend to have pretty much the same side effects except ACE inhibitors. Another thing to know is that they have a cough that can arise. It's one of those uncommonly common things. So if somebody comes in and they have a potassium of 3.1, the first thing that you should do is look at their history and look at their medications, because say they're taking hydrochlorothiazide, that would alarm me. Oh, it's probably from the medication that the patient's on. So yes, you will give them potassium replacement, but just be aware why. It's always going back to the history, and one of the first things you do is take a look at the medications. And again, as I said before, the loop diuretic, the Lasix, if they're getting treated for heart failure to get that extra fluid off because they're retaining it, potassium is huge. It has to be monitored very closely. So again, make sure you're watching that potassium, that serum potassium level. The next one are beta blockers. Beta blockers work by decreasing the workload in the heart with the beta cells. And with that being said, we watch for heart rate, fatigue. A lot of these people have exercise intolerance. But overall, know that this decreases blood pressure and heart rate. Calcium channel blockers is another one. Those are your ENs, amlodipine. Beta blockers are your lulls, like metoprolol, indirol, labetalol, carvedilol, and which you should have learned in pharmacology, going back all the different classes. Calcium channel blocker, most commonly, you have to watch for leg swelling. Most of these medications, including ACE, ARB, diuretics, calcium channel blocker, you should monitor labs, especially your kidney function and your electrolytes, particularly your potassium. So one very important thing that I want you to keep in mind with anybody with hypertension, you have to do education. And I'm going to just erase the page on this. All right, so education for high blood pressure pills. So when you're telling them that they're starting on a medication, it's very important that you tell them to change position slowly. Because number one, especially if they're naive to blood pressure medications or if you're changing a dose, but regardless, what's it doing? It's dropping their blood pressure. So if you're laying down all night, it's gravity. And then all of a sudden you sit up and start walking around, what's going to happen? If you're on a blood pressure pill as it is, the blood starts going to your feet and leaves your head. And that's when some people get dizzy, when they're headed to the bathroom or just getting up quickly. So when you're on a blood pressure medication, it's even more important to make sure you do that teaching. The last thing you want is your patient to have a fall. Another part of education is also done in an outpatient setting. So if you are checking your family's blood pressure, or even in the hospital, you're checking blood pressure and it's consistently high, you really want to tell them that they need to be seen, because again, prevention and treatment early is what is really important.